All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. It helps, these exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
Times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So
Indeed.
Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone, and welcome back to the GynoCast. My name is Dr. Eric Heegaard. I'm board-certified OBGYN.
Yes,
I'm
you
here
are.
with Twila. Dang!
Why do you always say my name like that?
I don't know. It's just so fun to say.
Well,
It's a fun thing to say. It's
It's
not
a
like
good
saying
name.
Marge Johnson.
that's true. I've
No
got
offense to Marge Johnson's
Yeah,
out
because
there.
you're going to get some emails.
Yeah, but
I didn't
Marge
say it, Marge.
Johnson's kind of fun. But
Yeah.
but Twila, dang, it just rolls off the tongue.
I know.
It's got these clashes to it.
Clashes.
Anyway, yeah, like TD, Twila, dang, boom.
Oh,
It's
I never
it's
even thought about
percussive.
it.
It's percussive. It's there's a cadence to it. It's just fabulous.
Well, that's good. I'm
Yeah.
glad I could provide that today.
So for those of you who are new to the show, welcome aboard. We're so happy to have you listening to us, and for repeat, recurrent listeners, thank you and welcome back. We adore you as much, and perhaps differently.
Okay. I'm going to let you have that today.
Yeah, we love you in a bluer
Okay.
versus we love the new ones greener.
Oh,
That's-
I'm totally going to let you have that
All
today.
right,
What are we
you're not going to argue with that.
No.
Hey,
What are
so
we talking about today?
for those of you who are wondering, what is this show? Well, Twila, you're so good at doing this. Okay, don't do it. I'll do it.
This is the part where they're not supposed to see how the sausage gets made.
Twila's like whacking her head. Okay, well, we talk about everything and anything that has to do with women's health. We talk about the subjects that you really want to discuss, need to discuss, but maybe don't want to talk to your mom about it.
Yeah, absolutely.
that?
Indeed. So what are we going to discuss today?
We are talking about hysterectomy.
Okay.
And there's been a fair amount of buzz about this on the GynoCast Facebook group with questions on there. And so it's interesting because from my standpoint, I think, well, everybody knows about hysterectomy, what it is, and et cetera. But this is because I do it all the time.
Yeah, that's true.
And but there's a lot of questions about this. And there should be when I think about it, because actually it is the second most common surgery done in the United States, and probably therefore in the developed world, if not the world. The first being what, Twila?
I have no idea.
Cesarean section.
Okay, wait. So
Then-
you mean the most typical surgery overall?
Yeah.
Like, or the most typical surgery for, like, women?
I'm talking about the most common surgery for women.
Oh, okay. Okay.
Yeah. And so C-sections, I think,
Yikes.
actually is the most common surgery, period.
Oh.
Hysterectomy, there are 600,000 hysterectomies done every year in the United States.
Really?
600,000.
That's a lot.
And, well, you think, is it a lot? Are we doing too many? This has been one of the questions that we've been talking about, and one of the things I want to address today. Because are we doing too many in the United States? Probably.
Okay.
And the reason I say that is that if you look at other developed countries, for example, we do in the United States about 5 out of every 1,000 women has a hysterectomy.
Okay.
In Italy, it's 3.7 out of every 1,000. So a little bit less.
Yeah.
In Norway, it's a little over 1. So 1.2 women out of every 1,000
That's it?
has a hysterectomy. So, I'd like to think that, Norway, Scandinavia, and Europe, as well as other places, have very high standards, caliber for medical care. And so the fact that there's such a discrepancy between what we are doing and what some of the other places in the world who also have cutting-edge medical care are doing makes me think that we probably are doing too many.
Okay.
And just like we've talked about cesarean sections in the past, where our rate is higher than other places.
Yes.
Not as high as some places.
Right.
But there's probably a happy medium in there where we are doing too many compared to other places. And so I want to talk a little bit about why we do them and the different routes for doing them, some of the controversies about hysterectomies, and the more common questions. We're going to cover that today.
Okay, sounds like a plan to me.
So, a little history.
Okay.
I'm bringing this back because when we used to do live radio in the past, Twila, one of the things I loved talking about was a section that we did called Herstory.
Yes, you did used to love that.
I love that.
I didn't love it.
You didn't love it? Well, because I think it was too heavy sometimes.
No, it was just not packaged well, and I wasn't in a position to tell you to package it better.
So you're
I'm in a position to do that
now. Twila just pound me. So now I want you to help me package this because I think
sounds like a plan.
This is what I find interesting about history, medical history, well, history in general.
Mm-hmm.
But we are, as human beings, the recipients, the beneficiaries, and sometimes and oftentimes the victims of our culture, science, and that sort of thing in terms of how we look at our bodies and illnesses and that sort of thing.
Mm-hmm.
And we still are. And the reason I say that is that our knowledge, what we do now, is different than what we did 20 years ago. It's not like, how we approach, for example, hysterectomies.
Mm-hmm.
And some of the questions we're going to talk about today, do you remove the ovaries? Do you leave the ovaries? Do you remove the cervix? Do you leave the cervix, et cetera, is different. Our recommendations now are different than they were 20 years ago.
Right.
And so this is not something that is, we all know that we do things differently than we did 1,000 years ago, right? And that's ancient history.
Yeah, essentially.
But history and medicine, philosophy, all that stuff is living and breathing and changing, and things are changing all the time, even within 5 or 10 years in how we do things. So I think it's interesting to look at what we've done to keep in mind where we are and where we're going to be.
Okay.
And so, how do you like that? Am I doing okay so far?
I'm in all right.
Okay, so now I know you know this, but I'm going to say this anyway.
Okay.
So when you talk about the uterus, why is removing the uterus called a hysterectomy? Do you remember this?
Doesn't it have to do with like the word hysterical?
Exactly.
Yes.
And so in the history of hysterectomy, can be traced way back to the Greeks, and it was described actually by Plato, one of the obviously a Greek philosopher,
mm-hmm.
and this just shows you how, in a certain point in time, you think you know everything, you got to figure it out, and you're completely wrong.
Right.
He thought that the uterus was a living creature that wandered around the woman's body. Wandered around.
Yeah, we have discussed the wandering womb.
The wandering womb,
mm-hmm.
which is funny because in retrospect we know that the womb does not wander.
Yeah, exactly.
In the villages and the valley.
Okay.
And so, but in addition to being sort of funny and quaint, charming perhaps, that sort of philosophy also led to a lot of pain and victimization of women, and they thought that the uterus caused hysteria, which is what is hysteria? It's probably nowadays we would talk about it being bipolar disorder, or depression, anxiety, schizophrenia, that sort of thing, as well as a lot of sexual dysfunction that people just were trying to figure out. And this idea.
Well, see, I feel like even back then the term hysteria was more of a blanket term for like women having mood swings and they didn't want to deal with it.
Well, perhaps so.
Because and I don't know if I think we've even discussed a long time ago. We discussed there was a movie that was made about that was set in the 1900s. About the man who sort of inadvertently created the vibrator.
Oh yeah, exactly.
Yeah, and it was to help treat hysteria.
Yeah, and
he essentially was just using vibrators on women, and it was like, "You're cured. Come back next week."
He was very popular.
Yes, indeed.
Well, probably. So
the movie made it seem like he was.
Yeah, they used to think that they would describe, however you want to define hysteria, and they thought that it could be treated by orgasm, which were also called hysterical paroxysms.
Okay, we're going to go back to calling them that. What did you say?
Hysterical paroxysms.
Hysterical. I'm writing this down.
So, some of these doctors back then were thinking, okay, well, the problem is that they need to have an orgasm or hysterical paroxysm. That would fix them. And they did develop the vibrator. What can you argue with that? But
nope, cannot. Thanks very much. Appreciate it.
And in addition to that, they oftentimes would recommend hysterectomy, removing the uterus to try to treat some of these things.
Yikes.
That is not what we do hysterectomies for now.
No.
So the most common reasons why we do hysterectomies, and by the way, the definition of a hysterectomy
is
removal of the uterus or the womb which wanders through the willage and the wally.
Okay, that's not a part of the definition. Stop that.
I just love
Is it just the removal of
the uterus?
So it's not like if you remove the fallopian tubes, if you...
That's an additional. That's an add-on.
Okay.
It's like fries. Right?
I shouldn't even said it. I set myself up for that.
If you ask for a hamburger, you get a hamburger.
My forehead hurts. I ran right into that. Sure did.
If you want a Happy Meal, you get the pie and you get the fries with a hamburger. So a hysterectomy is just the basic removal of the uterus.
Okay.
And we're going to talk about the different types of it and how it's done in a little bit. But basically, it is a removal of the uterus and otherwise called the womb. Why is it done? Well, historically and currently, it's done for a few main reasons. Number one, heavy bleeding.
Okay.
That's probably the most common reason for doing a hysterectomy.
Now, heavy bleeding, you mean by definition in excess of a certain amount, or? Well,
that's kind of a moving target too, because they used to say something on the order of 30 cc's per day. But how do you know anybody who keeps track of the number of cc's of their
remember we got into a whole situation where we tried to calculate cc's for situation, and I mean the
5 cc's.
Listen,
5 teaspoons.
Listen, the Facebook page just lit up with people fussing at us about, oh no, you did your math wrong. I was like, I am not a math major. Jeez, you guys! It was on the internet. I told you all about that.
We need to get one of those Cook's Illustrated, translations, cups to pints to liters and stuff.
You're laughing, but I'm going to get that done now.
So, but the way we look at it now is somebody bleeding to the point that it interferes with their quality of life, and that's a different podcast in some ways. So I don't want to spend too much on it, but basically. If you're having to change a pad or a tampon, leaking through a pad or a tampon, having to get up at night and change things,
like multiple times, or
getting blood on the bed, because you're
so essentially bleeding so much that you're routinely saturating clothing, things like that.
Exactly,
okay.
And so that's kind of it's more, how does this affect your life? Is it affecting your quality of life, interfering with your ability to do things?
And that tends to be a very large ground rule for almost all of these conditions that you talk about, is how it impacts your daily life. If it's altering your daily day-to-day routine,
that's right.
It's something to address.
Exactly. And if it's not a problem, it's not a problem usually.
Yeah.
So vaginal bleeding, pain, and then pain can be caused from a lot of different things. It can be caused from an enlarged uterus. It can be caused from cancer. It can be caused from fibroids. It can be caused from endometriosis or adenomyosis, which we will and have talked about. And so back pain, incontinence, bloating, things that interfere with your activities. And so those are the most common reasons why they are done. Are they valid? Yes, they are valid. Hysterectomies help with virtually all those things in the right person. And so I'm going to get back to this, that do we do too many hysterectomies in the United States especially? I would say probably, because for almost all of those different categories, those complaints, bleeding, whether it's bleeding or enlarged uterus or back pain and that sort of thing, oftentimes there are other procedures that are less interventional than a hysterectomy that can be helpful. And so this is why I want to kind of talk about this, because I think it is incumbent on patients, and we talk about this a lot on the GynoCast, to advocate for themselves, to ask questions, because oftentimes there's more than one thing you can do.
Now, would you consider a hysterectomy kind of a last resort option, or would you consider it? Okay, so you should really and truly be asking those when you talk about advocacy, you should be asking, are there other procedures, are there other ways to treat the symptoms that you may be having before you jump immediately to hysterectomy?
Exactly, because with any procedure, the more complex it is, the more invasive, the risks are higher. And there are possible side effects to hysterectomies, beyond just the fact that you're removing a part of your body.
Oh.
And so I would like to think that if you are careful in discussing the options with a patient, almost universally, she will be happy after having a hysterectomy. The quality of life, her satisfaction will be very high, because if you choose the patient right and you choose the procedure right, it'll make a huge difference. Now, if you're doing hysterectomies that are unnecessary and perhaps unwarranted, then the chance that somebody's going to be unhappy with the results is going to be higher.
Well, especially given the idea that there are side effects that can happen from a procedure like that, and if you didn't necessarily need the procedure, and all of a sudden you're in this position where you've now done it, and now there are sort of consequences to doing it.
That's right. And so my approach, and I think most people try to go down a line of increasing intensity of procedures or invasiveness.
Yeah.
You start with the least invasive, least risky, and move down.
Mm-hmm.
Now, in most people, surgical procedures, including hysterectomies, are very safe. But they're not completely safe. Just like driving a car. In Minnesota, the chance of dying in a car is about 1 in 14,000.
Okay.
So we all think it's, we all make these decisions all the time, but there's always a chance that something could go wrong, and you want to feel like you have done your due diligence and you've thought through things so that if something doesn't go the way you want, you at least can feel like my doctor and I, we thought about this carefully.
Yeah, absolutely.
We were deliberate about it, because it makes dealing with something that goes different than you want much easier if you feel like you've gone through the process.
Well, and that's just a good time to reiterate the point that at the end of the day, if you are going to see a medical practitioner, you are still the customer. They are still seeking a service from them. So when you cross over into a doctor's office, you don't automatically become voiceless, and you don't automatically become somebody who cannot and is not allowed to state, their opinion or their preference or their discomfort, just because somebody has a medical degree and you don't. They still work for you.
That's right.
And you're still allowed to ask for that level of care. It doesn't matter if you have to ask the same question 27 times to get understanding.
That's right.
Ask as many times as you need. Get another opinion if you deem it necessary. Really have the discussions that you need to have to feel comfortable. It's still your body at the end of the day. And even with their expertise, you have to go through it. So you're allowed to advocate for yourself, and you absolutely should.
That's right. And so you want to, and so adding on to what you're saying, you want to ask questions like, for example, how many of these do you do? If somebody operates once a month on one patient, that's not very much.
Yeah.
Because there's no, every hospital has credentialing, and if you do a certain amount a month or a year, you can be credentialed to do what you're trained to do.
Mm-hmm.
But everybody knows the more you do of something, the better you are. And so you want to find somebody who does a lot of these. So when we were talking about the indications for hysterectomy, for example, bleeding. Well, bleeding can be caused from fibroids. They can be caused from cancer. They can be caused from sometimes, a polyp or something inside the uterus. There can be a lot of reasons for it. Mm-hmm. If you have cancer, you want to be operated by a cancer surgeon.
Yeah, absolutely.
And for example, if you have fibroids, you want to be operated on somebody who has done a lot of work with minimally invasive surgery from that capacity.
Well, and that's actually a really good point. And we'll probably, I actually feel motivated for us to do an additional episode later on about the idea of sort of what kind of, I think as a patient, you don't always even know what to ask.
Right.
And you don't know how to approach your doctor in a way that you may personally not take they wouldn't take it as offensive. And especially for women. I mean, this show is geared toward women. It's about women's health.
Right.
Women are loath, for the most part, to offend or hurt anybody's feelings. So the idea of asking a doctor, hey, you recommended hysterectomy and I agreed to it, but can you tell me how many of those you've done? That is mortifying to many women. The idea that I would even question your expertise or question your ability or question your experience level is... I mean, many women would just immediately just retreat at the idea of having to do that.
That's right.
But these are absolutely valid questions to be able to ask. And I think some people don't even know where to start. So sidebar, you get credit for that, because we'll probably do an episode about how to ask those questions tactfully in the future.
Well, and it's important to be tactful and to be polite and all that. But a doctor who gets defensive is a doctor who probably is not very confident.
Yeah.
You will find that doctors who do a lot of something are much more likely to say, you know what, I do a lot of this, I'm good at this, I don't do so much of this, I'm going to send you somewhere else.
Yeah, absolutely.
So the doctors who say, yeah, I can do that, they'll just kind of do everything, that should raise a little bit of a red flag. I think the thing that shows the most confidence in a doctor and in the doctor herself or himself is when they say, I'm good at this, I'm not good at this, I feel more comfortable sending you somewhere else.
Absolutely.
And so these are questions that you need to ask.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
One of the other reasons for hysterectomies, it's one of the more common ones, is prolapse, the uterus coming out and falling down.
Okay, and we have done an episode about prolapse.
That's right.
Put it in the show notes on the website's page, so you can actually reference that episode as well.
That's right, and that's another area that is really a moving target, and how we treated prolapse when the vagina comes down.
Well, and just in case somebody doesn't know, tell them real quick what prolapse
prolapse is when the uterus or the bladder or the rectum and or all of them can start to fall down into the vagina, and sometimes actually come out.
Yeah, thanks, gravity.
Yeah, gravity and babies and genetics and all that. So
thanks for being a woman.
And so depending on the severity of the prolapse, and it kind of has bearing on who perhaps should be operating on you and what kind of procedure you should be having, because sometimes there's more than one thing that needs to be done. And so if you have a really bad prolapse, if your uterus is falling out, literally like, hanging out of your vagina, you may want to have somebody operate on you who does a lot of surgery for prolapse, someone like a urogynecologist, or which is somebody who's subspecialized in both gynecology and urologic surgery, also called pelvic surgeons, or along that line. So there are people that do a lot of that, and you want to have somebody who does a lot. And so these are things about just advocating for yourself. And so how are hysterectomies done? They're done a lot of different ways. Historically, they would be done with a big incision, like a C-section.
Okay, so across your...
Yeah, an abdominal incision. And also vaginally. So you can take the uterus and the cervix out vaginally.
Okay, so I got a question. Is there a reason that there's different kinds because of the possibly having to go at it a different way depending on how bad things are in there, or is it just stylistically they started out doing it one way and then they switched to doing it another way?
Well, both. And so, for example, and these are some of the things that when you're talking with your surgeon, you figure out what's the problem, what are the symptoms you're having, and then what is the best way to manage it. And so if you have a huge uterus, let's say you have a fibroid, which is a benign muscle tumor of the uterus that is the size of a basketball. Well, that's probably, number one, that's rare.
Yeah, but still.
But it's unlikely that most people would take that on laparoscopically or vaginally. And there are people who do a lot of things and push the envelope, but most people would say we're going to do an abdominal incision for that, just because the uterus is huge. Certainly cancer. A lot of cancer surgeons now are doing many of these procedures laparoscopically and robotically, and they're very good at it. But not every one of these cases is amenable to that. It also depends on the training and the comfort of the surgeon. So a lot of people have done a lot of vaginal hysterectomies. They're really good at it. That's how they like to do it. And if it meets the right parameters, it's a great procedure.
Okay.
It's a great procedure in some ways. A good, somebody who has a vaginal hysterectomy, the recovery time for that is better than just about anything else.
Okay.
Because you don't have any abdominal incisions or anything.
What's
like that.
the usual recovery time?
Well, it depends on what you mean by recovery. In terms of being able to get up and walk around, no matter how it's done, you'll be up and walking around either later that day or the next day.
Okay.
Usually in about 2 weeks, people are 80% back. 6 weeks, 95% back.
Okay.
So that's why a lot of times we give this kind of arbitrary amount of time of 6 weeks for full recovery. And so, again, I do a lot of, most of my surgeries are robotic-assisted laparoscopy. So what I do, I just personally, for my patient population, vaginal hysterectomies are not the best thing. Because most of my patients are endometriosis, adenomyosis patients
So there are other real complications that
Right.
Don't allow for that particular for one type of surgery over the other.
Right. So these patients are not good candidates generally for a vaginal approach, because oftentimes, in addition to taking the uterus out and a hysterectomy, I may be taking the ovaries out. And oftentimes I'm removing endometriosis at the same time,
Mm-hmm.
and so I need to see. But for somebody who's having a hysterectomy, for bleeding, the uterus is normally sized. To do that procedure vaginally is probably a perfect procedure for them.
Okay.
And so these are things that you just need to advocate for yourself. And when your doctor says, well, I want to do it this way, say, well, why aren't you going to do it vaginally? Or I think the better question would be, why are you making an incision? Because still, around the country, the percentage of women who have hysterectomies with a big incision, like a C-section incision, is extraordinary. It's like, it used to be something like 80%. Now it's probably 50%. It's still, whereas at OBGYN West, where I operate, we probably have less than 5% of people we open for a hysterectomy. It's just incredibly rare, because we're just really good at minimally invasive robotic surgery. We can manage a lot of complicated pathology laparoscopically.
Okay, so why do you think that number, that surgical number for complete an abdominal incision, is still so high?
It's training. It's just you get what you are trained to do is what you do.
Okay.
And so a lot of people were trained to do the things abdominally. That's what they want to do, and they're good at it, and they're just not as comfortable with minimally invasive stuff. And so that doesn't mean they're doing anything wrong, but that because you want somebody to do what they're comfortable doing.
Yeah, absolutely.
And so, but there's a lot of different approaches to this, and it just depends on what you're trying to get out of it. Now, I want to talk a little bit about what some of the major sort of arguments are about hysterectomies, because these are some of the things that were on the Gynocast Facebook group, and some of the questions that that people ask me, which I think are very, very good questions. Which is, for example, there's been a debate going on for literally over 100 years about whether we take the cervix or leave the cervix.
Okay. What's the pro and the con?
Well, so it used to be that people thought that if you left the cervix in place, that there would be less prolapse, because much of the support to the top of the vagina and the uterus inserts right with the uterosacral ligaments at the level of the cervix. And so if you leave those ligaments intact, that they'll be less likely to have the vagina kind of fall down,
because there's still a support mechanism there.
Right.
Okay.
And so there was also some question about whether there was improved sexual function with people if you leave the cervix intact, because some people, and this is actually true, that there's a small percentage of women who really notice a difference, and they have vaginal orgasms or orgasms that involve their cervix. It's a very small percentage, but if you're talking to somebody, and this is a question that I oftentimes will ask, is most women will have clitoral orgasms,
right,
but a small percentage will have orgasms that really involve the cervix, and those are people that, unless you really need to take the cervix, you want to leave that in place.
Well, exactly.
But there was a good study in the last 5 or 10 years, I can't remember how long it was, that pretty much debunked that said that whether you leave the cervix in place or take the cervix doesn't really have any significant difference between prolapse, future prolapse, and sexual function.
Okay.
It's basically the same.
So if the study comes out and it debunks it, so then then it becomes just a preference?
Well, so some people will I've had women just say, I want to keep my cervix. And I don't mind that because the real downside to leaving the cervix in place is that you need to have pap smears, just like you had before.
Okay.
If the hysterectomy is being done for reasons other than cancer, once you get the uterus out, you never have to necessarily have a pap smear again, which is kind of nice.
Yeah. Hey.
And the other thing is, if you leave the cervix in place, there's a small percentage of women who will continue to bleed. And so because there's endocervical cells that line the inside the cervix that can bleed. And so that's more of an annoyance than anything else. But again, in my patient population, it's a little different because I work so much with women with endometriosis and pain. and adenomyosis, which is kind of a variant, if you leave the cervix in place, almost invariably 3 years later, you're going to be going back to take it out because endometriosis will occur on the top of the cervix, and then you're talking about a much more complicated procedure. So for most women, probably taking the cervix is the better option.
Okay.
But, people still have debate about it. And again, like I said, I've had women who say they want to keep it. I don't really argue with them as long as they don't have a history of severe precancer or cancer or we're doing it for reasons other than pelvic pain or endometriosis.
Yeah.
There's also a question, and so the answer to that question is you could go either way, but there's no evidence to support leaving the cervix in place for most women.
Okay.
Number 2, the other big question is, do we take the ovaries out?
Okay.
That's something that has been going on. It used to be when I was in training, a couple decades ago, if you were in your 40s, we took those ovaries out.
So you just did it. So when I want to remember if it felt like there used to be terminology. I remember being a teenager and my mom's friends and their friend group were sort of going through processes like this. And then there was I don't know if they referred to it as like a partial versus a total hysterectomy, but there used to be sort of that discussion of we took everything versus we didn't take everything.
Right, and that's where these kind of terms get kind of loose, because in my mind, a total hysterectomy and the way we generally define it in the business is you're taking your uterus out and your cervix.
Okay,
kind of all.
I gotcha.
And the cervix is part of the uterus, but it's kind of like a little bit of a different animal.
Okay,
on the same organ.
It has its own identity.
It does,
okay.
And whereas, if we're going to take the tubes and the ovaries, we say a total hysterectomy with bilateral salpingo-oophorectomy, meaning taking out both ovaries and tubes.
Bingo, because I don't know what you just said, but I get it.
I know. We
got real doctory for a second.
I just had to throw that out.
That was good. Okay, so if you're talking about taking out the ovaries,
right.
In addition, what's the pro and the con?
Well, so the why we used to do it is that the argument that was made, and there's some validity to this, is that if you take out the ovaries, you're reducing the chances someone could get ovarian cancer in the future.
Okay, I see that.
Which is totally valid.
Mm-hmm, absolutely.
But the chance of the baseline risk of someone having ovarian cancer is about 1 in 70 over their lifetime, so less than 2%.
Oh.
So it's really low.
Right.
And
unless you have some sort of family history.
Right. And so in general, and we are talking now, it's a little fuzzy again, but people are advocating leaving the ovaries in place, and many women into their 50s and maybe even early 60s. If you're doing a hysterectomy, unless they have something that makes them at higher risk for ovarian cancer. Mm-hmm. And those are basically family history, especially in the case of an ovarian cancer syndrome, like the BRCA1, BRCA2. That's the breast ovarian cancer.
Yeah, those
syndrome.
isn't that like when you do the genetic testing looking for that in particular?
Exactly.
Mm-hmm.
Yeah.
Mm-hmm.
Or there's another genetic cancer syndrome called Lynch syndrome that also increases a woman's chance of getting ovarian cancer. Mm-hmm. And so in those situations, you definitely want to remove the ovaries. But for most everybody else, oftentimes you can make a good argument for keeping them in place. Other people that you would want to take the ovaries out on are people who have other ovarian pathology like endometriosis, pain related to adhesions or scarring of the ovaries, and that sort of thing. So there are other reasons to take ovaries out. But if there's not some pathology related to it, if it's just that the woman has ovaries and she's 50 years old, mm-hmm. We should probably keep it in place, because even when a woman goes through menopause, average age is 48 to 52, mm-hmm. Her estrogen levels start to go down and progesterone levels go down as well, but testosterone levels still continue. So when you remove the ovaries of a woman, you are putting them surgically into menopause, and boom, no estrogen, virtually no estrogen, no progesterone, no testosterone.
Yeah, and that's a big deal if you're doing hysterectomy, based on like bleeding or something else, and they're fairly young. Exactly.
And so this is where that argument, I think, becomes more important, mm-hmm. is that there have been a fair number of studies that seem to show that in younger women, and by that I mean less than 45, sometimes even less than 50, that if you remove the ovaries without a good reason, mm-hmm. that there is an increased risk of just overall lifetime death rates.
Really?
Yeah, a little bit, and it's not huge, but they just. And,
hey, listen, 1% is more than enough for me.
Yeah, and so, you have to make this decision carefully because when you remove the ovaries, like I said, you're cutting out all those hormones, and so women can be at increased risk of osteoporosis, which is bone thinning, cardiovascular disease, heart attacks and strokes, and that sort of thing. Sometimes there's some suggestion increased risk of anxiety and depression, and some cognitive brain function decline. And most of this is just is due to just lack of estrogen.
Right.
But in women who take estrogen, younger women who have had their ovaries out and who take estrogen, those risks seem to be much less. And so if you're, so then the take-home point is that if you are going to remove the ovaries on somebody who's young, unless there's a real contraindication to it, you want to try to supplement them.
Okay.
For symptomatic relief and also prevention for some of these other things we were talking about.
Okay.
One of the other things that people ask me about is sexual function, and this is beyond
it's
just
important.
Yeah. Beyond just the drop in hormones and stuff. But people are worried about, am I going to have pain? Am I going to have any other issues related with sexual function? And the answer to that question is that really, if you choose your patient carefully, meaning if you go through the process we were talking about, Twila, which is you're sitting down, you're identifying what the problem is, you're going through the different options for management, and finally you get to the level of deciding to do a hysterectomy, those women tend to have improved sexual function and quality of life.
Okay.
Because a lot of times, when a woman is bleeding, when she's got a big old fibroid, when she's got pain.
Well, yeah. We've already established if it's altering the way that you live your life, that means you're probably not living your life in the way that's most comfortable and happy for you. So
that's right.
Finding a way to get treatment will automatically put you back on a path to be living a better life.
Exactly. So
I can see how that will work.
If you do things right, if you choose your patients carefully, women in general will notice and improve.
I'll admit that when you first said that, I was like, oh, wait, what? Because at first it sounded like you were like, choose your patients carefully, like no jerks. It's like how I have a no jerk policy at our company. Like I don't like I only hire people that I really feel passionate about working with, and I only hire people I think are really great, and I see something in them, not just on on skill level, but personal level.
Yeah.
The idea that I don't choose jerks. So when you're like, choose your patients carefully, I'm like, how are you allowed to have a no jerk policy? You're a doctor.
Maybe I should change that a little bit, but meaning if you make your decision carefully, choose the patients you're going to do a hysterectomy on, they will notice almost invariably improved quality of life, improved sexual function, because their misery level has been reduced substantially.
Absolutely.
And most women who are miserable are not terribly interested in sex.
Yeah. Well,
maybe I'm wrong.
Well,
but people are bleeding all the time.
Not comfortable.
Yeah.
No. Okay, we didn't get a chance. Have we talked about the side effects at all of these procedures?
Well, so, again, I think we've kind of covered it in bits and pieces. So, the side effect of a hysterectomy is that, again, some people will know there is some change in anatomy. But, again, if you're, so if you were doing a hysterectomy on someone who had absolutely no symptoms and there was no reason for it, the side effects or the probable changes after surgery would be intolerable. But if somebody's got, again, if they're miserable, if they're bleeding, if they're in pain, et cetera, if they have cancer, the side effects of these surgeries are generally positive.
Yeah, absolutely.
And so again, the main side effect that people are worried about is, sexual side effects that we were just talking about. Pain, but generally pain improves. And so there have been studies that show, for example, that if you look at the most common symptoms, bleeding, pain, back pain, issues with limitations in a woman's ability to do what she wants to do, bloating and that sort of incontinence, loss of urine, that if you look at before and after, for example, many women who have hysterectomies, almost 60% of them have heavy bleeding. Well, after surgery, that's virtually gone.
Oh, okay.
Because the thing that was bleeding is gone.
Yeah, absolutely.
And pelvic pain, for many women, if you choose them right, and again, 60% of women may have pelvic pain before, and less than 10% will have pain afterwards.
Okay.
Back pain, again, fatigue, abdominal bloating, significant improvement in those. And so the side effects are an improvement, are positive, I should say.
Okay. So, well, I mean, I think that's fair.
So, bottom line, we're going to wrap this up in a nice little bow.
I like it.
Which is, hysterectomies are common. Do we do too many in the United States? I think we do. And I think that is based on kind of a responsibility on both sides, which I think is maybe lack of creativity and on the part of doctors who maybe aren't willing to do other options that are less interventional, but also on the part of patients who sometimes ask for them and are also not doing their due diligence about advocating for themselves.
Okay. So, in other words, patients become informed, ask your questions,
That's right.
very much treat hysterectomy like a last resort, not a first option,
Right.
and make sure that you're advocating for yourself and your health at all turns.
Yeah, and because I will tell you that if you, as a patient, are careful about going through the options for managing whatever problems you have, and your physician or your surgeon is doing the same thing, you will be happy at the end of the day. You'll look back a couple months after your hysterectomy, and you will think this is the greatest thing I've ever done.
Absolutely. Well, we're going to make sure we put all the information about today's episode up on the syllabus. You can go to matriarchdm.com and get more information. Just click on the show tab for the GynoCast, and we'll have the syllabus to the episode there, as well as other wonderful information. And if you haven't already, you should be a part of the Facebook group.
You should, absolutely.
Yeah,
it's life-changing.
So he says.
Mm-hmm.
So I live. So it's true. Go to Facebook, type in the GynoCast in the search bar. You should like the page and request to join it. It is a closed group, very specifically because what we talk about are sensitive topics. We talk about them in a very mature and dignified and
That's
social way. And we want to make sure that those conversations are safe spaces for people. So we vet you really quickly. We let you into the group. We talk about the topics on the show. We talk about things going on in the news. We answer questions. We provide support to the members. We are about 1,800, almost 1,800 strong, and we are growing. Yeah, we want those numbers to keep growing. So feel free to contact the Facebook page and join it today. And as always, we really appreciate getting to do this.
That's right. Thanks for listening. See you soon.